So I have not much to disclose. I'm neither a neurosurgeon nor an obstetrician, to make that clear from the start. I'm happily married for about 46 years. I have 4 adult children, 2 of which are lovely daughters. I have 6 grandsons and 2 granddaughters and 2 more on the way. So that's my experience. We're going to try to handle a number of questions. I frequently get asked to see patients that are either anticipating a pregnancy or are pregnant or anticipating labor and delivery. So these are the kind of questions that come up most frequently, and we'll anticipate the question. I hope we have a good discussion. Does pregnancy affect fertility and the ability to sustain a pregnancy? What are the risks that my baby will have a Chiari? Do I need to have surgery before I get pregnant? What about medications I take? Is the baby at risk during a pregnancy? Will my Chiari symptoms get worse during a pregnancy? Will a pregnancy make my Chiari symptoms worse so that I have to have surgery later? What are the anesthesia risks of labor and delivery as they relate to the presence of a Chiari-1 malformation? And what are the options for pain control, and how safe are they? How does having Syringomyelia, which is a real important question, influence my options? So we're going to handle these kind of one by one. Does Chiari affect fertility and the ability to sustain a pregnancy? Not that we know of. But it's important to recognize that about 10% of couples have difficulty conceiving. That's just the norm, whether you have anything at all wrong. It often takes a number of perfectly timed cycles before a pregnancy is achieved. Not everybody realizes that, although everybody experiences it. The chances of getting pregnant each cycle varies a lot with age. So between the ages of 20 and 25, your chance is about 25% per cycle. Between age 25 and 30, about 20%, and between 30 and 35, about 15%. And after 35, about 10% per ovulatory cycle, and the chances continue downward trend with age. So to put this in practical terms, the average woman and couple under 30 will get pregnant within about 6 months. About 6 months of trying, that is. All things otherwise being normal and equal. Women in their early 30s on average by about 9 cycles, and mid-30-year-old women could be up to a year. At any age, fertility docs and OBGYN people consider you a person infertile if they have been having regular unprotected intercourse for a year without conception. However, a woman over 35 would seek treatment maybe after 6 months. So in a couple, after, say, a year of not successfully getting pregnant, assuming they want to get pregnant and they're trying, then the next process is possibly in vitro fertilization and other really assessments of the ability of the husband to have a motile sperm, an active sperm, and that there are no autoimmune issues, and that the woman is otherwise able to conceive. What are the risks that my baby will have a Chiari? So this is a complicated question. You've heard some about the genetics of it. Generally, it's thought to be quite low. In fact, 20 years ago, we thought Chiari was really just developmental and sporadic. Recent studies, as you've heard over the last 2 days, have indicated that there are some familial trends and that tend to be kind of dominant. So families that have generation after generation of someone possibly affected, certainly the likelihood of a child being affected is a little higher. This new information suggests that maybe it's as high as 10% family incidence. So it's not very high, somewhat similar to trends in like diabetes, for instance. Do I need to have surgery before I should get pregnant? Well, not necessarily. So the clinical symptoms, really what drive the surgery. The indications for surgery in Chiari, are what we say usually are threefold. Symptomatic, significant symptoms with a Karnofsky score of less than 70, equal to or less than 70. So significant clinical symptoms, a progressing syrinx that's been identified, or active neurological symptoms that may relate to brainstem compression, such as sleep apnea, swallowing difficulty, tachycardia, bradycardia, dysautonomic features. What about the medications that you take? Well, this is an interesting topic, and it's a little shocking sometimes. Certainly the obstetricians that everybody will tell you, you get pregnant, or even in the area of conception, you should be on no medications whatsoever, and actually no vitamins. There's a little bit of a debate about vitamin D now, and I think the obstetricians are beginning to say vitamin D supplementation may be helpful and a reasonable thing to do. But they have a classification scheme, which is illustrated over here with A, B, C, D, and X. There's a big gap here, you know, so X actually is really chemotherapy kinds of agents, ones that are positively and well known to have serious fetal abnormalities associated. These are drugs like methotrexate, Halcyon, and some sleeping medications like Restoril. Interestingly enough, there are a number of drugs that are better tolerated or not so risky. The shadowed, you can't really see the shadowed here, but the good studies here where they have some good information, because this is not fully evaluated, as you can take, because it's kind of a human experience, means they have adequate and well-controlled studies. So there's a lot of interest in preeclampsia and postpartum preeclampsia that we'll talk about, and the aspirin is often recommended for this, but aspirin actually happens to be a class D drug, and that there's some evidence of fetal risk involved in this, but low-dose aspirin is frequently given to help sustain a pregnancy. There's a lot of question about whether there may be coagulation predisposition with some disorders like MTHFR syndromes, where the individual may have the A and both the A and the C mutation, and homozygous for that, where they have an increased risk of clotting. Certainly patients with lupus and anticardiolipin syndrome may be on minor anticoagulants, antiplatelet therapy. But aspirin is actually a class D drug. So are Topamax, which used to be a class C drug, but has been brought up into the class D. Also, most of these are anticonvulsant medications. Certainly women with well-recognized and need to be controlled seizure disorders are on these medications nevertheless, but there is an incidence of what used to be called funny-looking kids, which is not a very good descriptive term, but there are potentials for fetal abnormalities under those circumstances. So most drugs that we see come under the C classification, and it's interesting to know that a good pain reliever that's often used, oxycodone, Tylenol, and that are class B drugs, that there really isn't any good studies that can attest to some bad outcomes. Pyridoxine and vitamin D in low dose may be the only ones that people approve as saying, hey, there's nothing really to worry about there. So is the baby at risk during a pregnancy? Well, the good or the bad news is that every mother and every baby are at risk during every pregnancy. The infant mortality rate in the United States is under 1%. Just to give you some background statistics, the incidence of birth defects is 1 in 33 live births. So there are chances of things, whether you have a Chiari or not, that there may be birth. These are not all serious problems, but they're kind of the recorded incidents that are out there in national statistics. Every mother puts herself at risk during a pregnancy, and there's no such thing as a risk-free pregnancy. God bless women who get pregnant, because it's not only one of the most mystifying experiences, but it is a blessing, and it is not without hazard. So I usually tell every woman takes her life in her hands when she gets pregnant, and it's nonetheless a serious business. Probably second only to raising children, which is the other issue. So probably the greatest risk to the mom and child is preeclampsia. There's been a lot of interest in preeclampsia, and I'm sure many of you have heard that term, but preeclampsia is a condition in which blood pressure, usually in the third term of in the third trimester of the pregnancy, the blood pressure goes significantly high, and there may be some fetal risk, intracranial pressure risks to the mother with such high blood pressure and vascular risks. So usually the management of that is pretty empirical and has been going on for decades, and it's the administration of something called magnesium sulfate, which is a vasodilator agent, really a long, well-studied and well-used, maybe not so well-studied, but empirically it works. So they frequently will give mag sulfate. The blood pressure usually tries to drop a little bit, and the thing that they most like to do is sustain the pregnancy until they can at least safely bring the child, maybe at least at a few weeks preterm. So termination of the pregnancy marvelously makes this syndrome go away. The interesting thing, and I have personal experience with this because one of my daughters had postpartum preeclampsia, and even as a neurologist dealing with a lot of headache-related problems, I thought, there's kind of an oxymoron, is preeclampsia postpartum preeclampsia. But it turns out that about 15 to 20% of the time, eclampsia or elevations with headache and blood pressure problems occur after the delivery. So my daughter had a C-section and was doing fine. She had epidural anesthesia, and about a week after the delivery, baby was fine, my daughter was fine. She started having serious headache. She's a nurse practitioner. She sort of thought that she was having maybe a low spinal fluid pressure headache or a CSF leak, which was unusual, not likely, because she had tolerated the week at home being fairly active without any headache. And this came on suddenly. Her blood pressure turned out to be 230 over 130. She had extremely high blood pressure. You couldn't barely get near her. She was in such pain, and she went in the hospital, and they promptly gave her mag sulfate. They didn't admit her to the neuro ICU or any other place. She didn't have any focal neurologic signs, although she was agitated, really from the pain. And the blood pressure effervesced, and she felt very fine. So in usual American tradition, they sent her home within 24 hours. And stopped the mag sulfate drip, and lo and behold, 24 hours later, she was back where she started with severe blood pressure elevation, severe headache. She went back in the hospital again, and this time they not only gave her mag sulfate again, but labetalol, which is beta blocker widely used to treat hypertension. She was on that drug for about a month, and blood pressure, she was never hypertensive. In fact, she tended to have low blood pressure. And everything effervesced, and luckily it was a happy ending to the story. The baby's fine, but there's been some recent interest in this, and actually the issue of preeclampsia kind of comes up to a new rubric of what are thought to be inflammatory conditions or inflammatory vasculitis. And there's some new data that women that have had preeclampsia, or I would assume postpartum preeclampsia, although it hasn't been very well studied, have some increased incidence of cerebrovascular and cardiovascular disease 15 and 20 years after I don't know if the woman in the room, has anybody did have preeclampsia? Yeah, so there's one hand maybe. So it's not uncommon late in pregnancy, and it usually has a happy resolution, but we want to keep a closer eye on folks for the onset of later hypertension and possibly other risk factors, but there's more to be understood about that. Will my Chiari symptoms get worse during a pregnancy? Well, the good news is we've looked at about 40 historical pregnancies among some of our patients, and we continue to try to get and I would advise everybody to do this on the medical side of it, to get a pregnancy history so we understand how the pregnancy went, whether it's a normal vaginal delivery or a C-section, whether epidural or spinal anesthesia is used. But most women, in a few surveys that have been done, and I think Dr. Oro contributed to that, but there's very little written about this. Dr. Bolognese and I had a short summary in surgical neurology last year, But it's not been very well documented in studies. But the good news, just empirically and from my experience, and hopefully we'll hear some stories from the audience possibly, the good news is that in the second and third trimesters, even with reduction in pain medication or the elimination of Topamax, Diamox as well, people do extremely well. I had one young lady who had I think, a little over a 10 millimeter Chiari malformation. She was a very active accountant, and she had gotten married about a year ago, and she was anticipating having a pregnancy, and she was really agonizing about whether she should have the surgery first or have the pregnancy first, and so she decided actually to have the surgery first, so that she could, once a reasonable decompression is done, the options that are available to a woman are pretty much those of any other normal individual, because we don't have the risk of tonsillar herniation or other things. The issues with Syringomyelia are a little different. But so when she went in for her pre-op testing, lo and behold, her pregnancy test was positive. So she grabbed her head and said, "Oh, I stopped all my medications now," and she carried the pregnancy through. Really, to her own amazement, she had very little headache symptomatology. So pregnancy is kind of a blessed state. I know my wife always loved being pregnant, and she was happy and joyful, and it was just a good experience. I'm not sure everybody has that experience, but generally, it is, women are kind of placid, and I think that's part of the biology of how things work. I guess keeps people getting pregnant again. So, so the outlook, and I think you'll hear for other women's experience, also in looking back, we identify many Chiari patients in their 35 and 40s. They're kind of after their childbearing years, and they went through maybe 2 or 3 pregnancies, and when I take histories from people, and nobody knew they had a Chiari, and lo and behold, they have a 10 millimeter Chiari, and they had whatever. We need to document that a little better, but they may have had epidural or spinal anesthesia, and they really had very little in the way of complications. I talked yesterday, I think Dr. Trumbull mentioned about the issues of spinal taps, and some of the patients saying that even though there's some tonsillar descent, he had in his experience not encountered anybody that had with a reasonable kind of diagnostic LP had significant problems. Although that's always our fear. In an older population, neurologists now have a tendency to do an MRI scan before they do an LP, just to make sure there's not a supratentorial lesion or something else going on that may be at risk of an LP. And certainly patients with EDS have more of a tendency to leak from spinal tap punctures or epidural experiences that go and puncture the dura inadvertently. So that's remains a consideration. But generally, there hasn't been much in the way of reportable cases of serious problems following LPs. We talked a little bit about, just as an aside, the issue of catastrophic Chiari problems. And although we always say that Chiari malformations are not a life-threatening situation, but if you look in the literature, there are a few reports. There are less than a handful, maybe, of sudden death related to Chiari malformations. So the important thing is that a lot of those are related to opiate overuse, and we heard a lot about the risks of opiate overuse. Had a paper a couple of years ago of a patient that came into our experience who had been taking sleeping medications and actually died. It was discovered she had a Chiari malformation later, and so there can be the issues of central hypoventilation and obstructive sleep apnea and central apnea can be aggravated by sleeping medications and pain medications. So this is probably one of the biggest risks. The other is significant trauma. So if you get into a bad accident and you have severe intracranial trauma, certainly there's a risk of catastrophic central nervous system problems. But that's, there's a smidgen increase in the Chiari population, but it's not something for you to lose any sleep over, and that's the good news. The rule of thumb still holds that the more of the tonsillar descent, the more likely symptoms may be a little more prominent, but generally everybody does really pretty well. Will a pregnancy make my Chiari symptoms worse so that I have to have surgery later? Well, there's no way really to anticipate this eventuality. Chiari symptoms, we focus on the indications for surgery, and it's the clinical status, not necessarily the imaging pictures. You can have a horrible looking Chiari. As an example, I had a 65-year-old woman who was a mother of a physician. She developed trigeminal neuralgia, and lo and behold, she had a 20-millimeter tonsillar descent that she had lived with headache-free for 65 years. And so we treated her trigeminal neuralgia. Amazingly, she had no syrinx, and she did well. A few years later, she ultimately had a decompression because of progressing symptoms. But it's still perplexing how the symptoms and the appearance of the posterior fossa and tonsillar descent are not sort of always correlated. So what we're treating patients, not pictures. So the big issue is what clinical symptoms are. There are some statistics about risk factors, and we talked about this a little bit yesterday. And this may be somewhat overestimated because that thrust of that 1999 study by Dr. Miller, which had about 364 patients, was not really designed to look at some of these risk factors, but there was about a 25% incidence of patients saying that, after a head injury, they had progressive headache symptoms, and that's what tipped the scales in terms of recognition of their symptomatic Chiari. I went back to look at that paper, and you can kind of put numbers together, but if you figure out how many women were in the paper, which was about 275, there were about 16 women who recalled that the worsening symptoms occurred following childbearing experience, and that's about maybe a 6% incidence. So even at that, pregnancy and childbearing is relatively low risk factor in terms of progression of symptoms. So it's thankful, and we're happy that it's not one of on the list of significant causes of worsening symptoms. What are the anesthesia risks of labor and delivery, irrespective of the presence of a Chiari? So there are risks. They're minimal, but there are risks to being pregnant, all right? And certainly labor and delivery comes attendant with certain risks. And so if we look at the general population, the significant things that are talked about is epidural hematoma from an epidural anesthesia or spinal anesthesia, deep epidural infection, persistent neurologic injury, and those are, here's the numbers in terms of number per million deliveries. So the numbers are relatively low, and that's really the good news. One of the most common things that people experience, irrespective of the presence of Chiari, is post-epidural headache. So the need for anesthesia and where the rubber meets the road and delivery is pelvic dimensions. So you can't tell by looking at a woman and her hip dimensions and whatever, how easy or not a pregnancy is going to be. The obstetricians have a way of measuring some of these things, and so the general problem is called dystocia, which means that the baby can't fit through. And the problem with fitting is the head, all right? So everything else is fairly the shoulders, the hips, and that slide right through in a normal vaginal delivery, but the head is the biggest part that has to get through. So the bigger the baby, the more likely there may be a problem. And we like to not have to implore. Once the head gets lodged in the pelvis and there's only one way out, and that's to use forceps and take the child out. So we want to sort of anticipate this. Sometimes it leads to the maybe excessive numbers. In the United States, the incidence of C-sections is about 60 to 80% of labor and delivery, so it's a fairly high number. It's much less in other countries, and it's much less in military hospital. My first child was born after about more than 24 hours of labor, and I thought we were in a field hospital. They said, no, the baby's going to come out the regular way. So they were not too happy about doing C-sections. My second son was 9 pounds and 23 inches, and there was no question that, in fact, I talked to the obstetrician and I said, when I was in training, when I was a medical student, we had a flamboyant obstetrician, who said, all children are ready to go with a 200 IQ, and what they come out with is lost in the birth canal. I'm not sure that's true, but I don't know. Yeah, he turned around, and a couple minutes later, he said, well, we're going to do an emergency C-section. So, I'm not going to belabor some of the anatomic aspects of the need for pain control, but the options for pain control are several, and how safe are they? Well, many women are given Demerol as an opiate. We know we're trying to stay away from opiate analgesics, but these are actually, interestingly, among some of the safest drugs in terms of pharmacology of them. But they all slow labor, and they all slow contractions. So that's one of the problems. You get Demerol, and your contractions slow, and then the baby's not coming anymore, and then what do you do? There's not very much of, there used to be a lot more regional anesthesia or infiltrating the cervix, and I don't think that's done quite as much anymore, at least when you, partly in exchange for doing C-sections, which I guess is where it sometimes comes from women's population. After my wife's experience, I think, she would usually say there's no other way to, C-section is the best way to have the baby. It's a lot more painless. But it's not the same for everyone. And, you hear, I have a niece who's about 98 pounds soaking wet, and she's had 4 children. She has delivery in about an hour and a half, and she's the tiniest thing around. And then you have other individuals that just have more dystocia problems, and they need C-section. So it's a little bit hard to predict. The most common experience is epidural or epidural spinal anesthesia, and that's fairly common in the United States, more so than most other countries. What's the risk of epidural anesthesia? Well, it's kind of an inadvertent dural puncture. And the object in an epidural is to get the needle and a tiny catheter in the right position, not penetrating the dura, but getting in the epidural space, where there is ample room to inject anesthetic agents that percolate around this area, diffuse a little bit into the spinal fluid space, and the catheter is left in place so that they can control the administration of it. Now, epidurals are great. You can even have a C-section under epidural anesthesia, but they don't always work as planned. There's skill in placing this properly, and some individuals notice when they're side lying or whatever that they have more anesthesia on one side than the other, or it doesn't really get around, or they may have inadvertently had a lumbar puncture. And that happens maybe about upwards of 5% of the time. I think planning is the most important part of this, and sometimes the epidurals, it's all of a sudden we're looking at a normal labor and delivery, and all of a sudden it's pain escalates, and they say, okay, we got to get the epidural in, and it's hurry up, or the resident is doing it, a less experienced person, and there can be increased complications. So try to have them, if they're going to do this, make the decision a little bit more on the early side, have experienced, now they have really gynecological anesthesiologists in many of the large hospitals. That's all they do is take care of labor and delivery, analgesia, and anesthesia. The other way is to do a actual spinal anesthesia, and that means the needle is a much tinier needle. So the needle that goes, the size differential is not shown here, but in an epidural, the needle is quite a bit larger because they have a tiny tube that they place through there and try to get in the right place. But in a spinal, they use a relatively small needle, get close to it, and then use a tinier little needle to go through the dura. So the hole is very tiny, and they infiltrate anesthetic agent into the spinal fluid. Well, how good? It's oftentimes much better analgesia, particularly if a C-section. So the obstetrical anesthesiologists like to do spinal anesthesia. From the neurological standpoint, we're concerned you're puncturing the dura intentionally, but don't forget it's a smaller needle, whereas complications from an epidural is an inadvertent puncture, all right, an unintentional puncture, trying to get the needle in the right place or on several attempts to place it. And there are differences. One of the things that the anesthesiologists don't like to do, and that's general anesthesia. And I didn't really have much of an understanding about this, but they say, well, the general anesthesia, that's where they intubate you and put you under general anesthesia to safely do a C-section, get the baby out. There are risks. Maybe there's one of the questions is, does the anesthesia actually affect the baby? Are you putting the baby in that to sleep? They do this so fast that it takes only about 10 minutes or less. And so the anesthesia, most of the babies that come out, they have a pediatrician right close by, and they're ready to just take over if the baby's not breathing very well or seems to be under anesthesia. But usually the babies come out and they're kicking and screaming because they do this so fast. But the thing that the anesthesiologists don't like, they say that there's a lot of swelling in these tissues, that there's a chance of having reactive hypertension go on in the attempt to intubate somebody, even with pre-anesthetic administrations. So they don't really like it. And the obstetricians like to have the tendency now. I asked my mother about this years ago, and she said, well, pregnancy and delivery was great in my day. You went in the hospital, and they gave you some medications. You woke up 3 days later, and they gave you the baby. And it was called painless childbirth, And she said, it was marvelous, And then in my experience, everything was Lamaze and natural childbirth. You were a failure if you couldn't deliver a child, which was actually got to an incredible extreme, So there were groups of women looking down on women that needed any kind of anesthesia. If you can't birth a baby, you're not really a woman, So luckily, that approach has changed quite a bit. So I think it's much more balanced and appropriate nowadays. How does having syringomyelia affect my options? Well, this is a significant issue because not all syringes are equal. So if you have a very tiny syrinx, as you see here, really it may not even be a syrinx. And we heard yesterday that people are not calling a syrinx. You have to have a 3 millimeter or more. This is probably a millimeter or 2. So the tinier amount, really, there's not much risk. It's expansile syrinx that we're really worried about because there's a chance of, with pushing, which is a big job in the second to third stage of labor, that the syrinx might rupture or extend. We know this is much more common in post-traumatic syrinx than it is in dilated central canals, but there's still a little bit of a risk. So, of course, if you have a much larger syrinx, oftentimes between the patient, the neurology guys, and the obstetrician, they opt for well-controlled general anesthesia. Why are we concerned? The obstetricians like to opt for maybe doing spinal anesthesia, right? Because there's not much in the way of a leak, and you can give good analgesia, but there's still, and a C-section can take place. But we're concerned about, if you put air in the spinal fluid space, you can have inflammation. You certainly put analgesic agents in there, and spinal taps actually 60, 80 years, probably 60 years ago, got a bad name because people became paralyzed from giving childbirth when anesthesia that was epidural and spinal. Lumbar punctures got a bad name because many women developed arachnoiditis from the early use of anesthetic agents that weren't appropriate to be placed in the subarachnoid into the spinal fluid space. And so that, I remember going through my early years, people said, I'm not having a spinal tap, that can paralyze you. I've heard about that, I'm not gonna have it. But a diagnostic spinal tap really doesn't have a risk of that, certainly a risk of some leakage maybe. But so the important thing is that everybody's different, and there are a couple of caveats when we want to talk about Chiari patients with no prior neurosurgical treatment need to be handled with expectations driven by their prior symptoms and prior imaging, as well as their prior labor and delivery experience. As I said, the good news is many women get through this with little problems. The risks are wet tap and possible arachnoiditis from intraspinal anesthetics. But the risk of this is probably less than 1 in 10,000. So the anesthetic agents now used are really quite safe. And the anesthesia guy, we have a specific guy that heads up obstetrical anesthesia, and he always argues for spinal anesthesia approach because they like mommy awake and the baby on the tummy and bonding to start early and all the good news that happens after that. Patients who have been successfully decompressed can often have the full range of options dictated without much concern. The only caveat is the persons are not of a syrinx. Patients with syringomyelia ought not to push in the second stage of labor because of the risk of rupture of the syrinx cavity, and that's when there's really an expansile syrinx. That depends on the syrinx size. There's also, you never get away from that risk of chemical meningitis, but frankly, the response from my anesthesia is, can you show me a case of a patient that developed arachnoiditis following spinal anesthesia in the last 30 years? I said, no, I can't really, in my experience, I haven't seen it, but there's the potential to have it. And they say, well, there you go, it's really safe. So, hopefully there needs to be a little more research in that line. So the important thing is to plan, not only what the pregnancy is, and the labor and delivery, and how you're going to raise that child, and how you're going to find the money to send them to college. We suggest that people that know they have a Chiari get themselves designated as a high-risk pregnancy and see a high-risk pregnancy person. It's important to to make sure you see a good anesthesiologist before you go in for delivery. There's kind of problems with, this is kind of what I think pushes people more toward planned C-sections, is that you know who your obstetrician is, you know who your anesthesiologist is, and everybody on the team is all together with what the plan is. If you wait for the baby to get ready to go, you may get a resident. Sometimes you may have the delivery being supervised by a midwife. And so that ups the ante in terms of much less ability to plan what goes on. The other thing is that some people have a Chiari, and then we say, well, whoa, you didn't have full spinal imaging. Oftentimes we'll do MRI scanning in the 3rd trimester to see whether there's a syrinx. MRI imaging is quite safe, and the only issue is even if we don't know it, we usually wait till mid-3rd trimester till the baby is we're through the most critical embryologic developments in the development of the child. And most important thing is to have a team approach. And anesthesiologists being able to talk to you beforehand, being key with the GYN guy, and then the neurology person or neurosurgeon, more likely on the national scene, are together on what the best approach is, and bring champagne. All right. Thank you. Any questions?